Assalamu alaikum. I'm Wajeeha Rizvi. I'm a hematology oncology fellow at West Virginia University Cancer Institute. It's in Morgantown. And I'm a graduate of JSMU, batch 2011. So I would like to thank JSMU Wana for giving me the opportunity to do a lecture for you all. So today, my topic that I'll be discussing is going to be approach to anemia. I believe in Pakistan, we get so many patients, actually, not only in Pakistan, but globally, we get so many patients with anemia, and there's always this concern as to which one it is, going towards approach. So there's a lot of things that I would like to talk about today and hope that that clarifies the concepts today. All right, so today in the agenda, what we'll be talking about is the introduction to anemia, signs and symptoms, pathophysiology of the anemic process, how many types of anemia are there, diagnostic evaluation, and in the end, we're gonna do some questions even though it's not an interactive session, but I feel that after we've come across and covered major topics of anemia, it's going to actually help you all in consolidating all the information that we've learned today. So definition of anemia, reduction of absolute number of circulating red blood cells noted via two measurements on a CBC. One is your hemoglobin, जो कि बहुत important है, which actually is the primary thing which signifies how the intensity and the cutoff values of anemia that we actually consider. Your hematocrit or RBC count in the peripheral blood. The reason anemia is important, it's because of the carrying capacity of oxygen and the decreased oxygen concentration in blood, causing all these signs and symptoms that we're going to come across. So WHO criteria for anemia in men and women is hemoglobin level of less than 13 is considered anemia in men and 12 in women. And the exempt populations for this criteria are the athletes. Why athletes? Because they generally have dilutional anemia because of increased plasma volume. Also, they can also have the inflammatory process going on because of extensive exercises and the workouts that they do. So that can lead to abnormal readings that kind of gray the picture ke anemia hai nahi hai. So we keep different values for them. Also, the androgen use, erythropoietin use, those are the things that are also considered for that. Living at high altitudes and the requirement of increased oxygen over there, that also not only puts stress on the heart, but also leads to an abnormal reading for hemoglobin and polycythemic picture sometimes. Smokers, African Americans, older adults, and presence of anemia of chronic disease, all these population, in that we cannot go by the standardized definition of anemia with hemoglobin levels of 13 and 12 in men and women respectively. So looking at the physiologic response to anemia, low red blood cell concentration in the blood is what we call anemia. And when the red blood cell count is low, directly it's a feedback mechanism that tells the kidneys that, hey, there is low oxygen carrying capacity of blood, start making more RBC. And that's when kidney increases secretion of erythropoietin. And erythropoietin actually goes to the bone marrow and signals the bone marrow to increase the RBC production. So that is basically the effect of erythropoietin on the RBC numbers, which involves kind of activating your bone marrow to produce erythrocytes. So let's have a look at this diagram. In this figure, we talk about how the bone marrow is working towards increasing erythrocyte production. So in the bone marrow, we have multipotent hematopoietic stem cells. And once the erythropoietin activates the marrow, it increases the production of myeloid progenitor cells that leads to proerythroblast and basophilic erythroblast. polychromatic erythroblast, orthochromatic erythroblast, which are also called normoblast. And then when it enucleates, it leaves the marrow. And that's when it is called a reticulocyte. Reticulocyte, as we all know, we also see that count on the complete blood count CBC profile on the blood. And that reticulocyte further matures and turns into erythrocyte. So the process in the marrow takes about 21 days to for the red blood cell production, and then it takes 1 to 2 days in the peripheral blood for complete maturation of your red blood cell count. So all in all, roughly always like see the response of your erythropoiesis in a month's time, and that's how we also set up our follow-ups with the patient. So our red blood cell indices, what we actually look at on the complete blood count profile, which is MCV, which is the mean corpuscular volume, MCH, mean corpuscular hemoglobin, MCHC, mean corpuscular hemoglobin concentration. So the MCH and MCHC is the hemoglobin content in RBC. So that tells you the average content. Our red cell distribution width. This is actually very important because RDW values actually tell you the variation of RBC site sizes. As we all know that reticulocytes are larger cells, and as the RBC matures, it gets smaller, and the mature RBC, it's much smaller than a reticulocyte. So knowing the RDW, अगर आपके blood में RDW increase हुआ है, that means कि आपके पास immature RBCs are higher than your mature RBC. So that actually tells you and kind of hints towards the possible etiology of your anemia, if the patient has it, that is. So signs and symptoms. It's very important whenever आपके पास patient आता है anemia के साथ, or the key for every evaluation is the focus on history and physical, right? So in history, we have to talk about the rate and degree of anemia. So degree of anemia, yes, you will find out on the lab testing later on, but rate is something that you can actually figure out through your good history taking. Knowing कि ये anemia कब से है, या ये signs or symptoms of fatigue, dyspnea at rest, bounding pulse, or confusion symptoms, dyspnea on exertion, ये सब कब से हो रहे हैं. So that actually tells you if, for example, if it's an acute process, maybe patient had a trauma, maybe patient had a motor vehicle accident, and that caused the patient to come in with acute anemia. Or if you're talking about someone with, let's just say, GI bleeding, right? If it's acute GI bleeding, like gastric ulcer disease, varices, anything that happened acutely, and there was acute symptoms, then you know that what is the intensity and severity of anemia. But for example, if patients have AVMs, and if they have, for example, diverticulosis. So those are the things where you usually see a very slow drop in hemoglobin. Like slowly they would have melanic symptoms, they would have melena, and sometimes the loss of blood in stool actually even just goes unnoticed. So we have to figure out how acute it is and what's the degree of anemia, right? So symptoms, we talked about dyspnea on exertion, dyspnea at rest, fatigue, bounding pulse, confusion, and then signs. That's based on your physical examination, which is your pallor, low oxygen concentration in the hemoglobin, that leads to that, rapid pulse and breathing, compensatory mechanism, cholonicia, jaundice, which hints towards hemolytic anemia, enlarged lymph nodes, which is an indication for malignancy, lymphoma, or other myeloproliferative disorders, splenomegaly, glossitis. So these actually hint towards what could be the etiology of anemia. Life-threatening complications of it could include congestive heart failure, arrhythmia, hypovolemic shock, and death. And this hypovolemic shock and death actually is more because of your acuity, like acuteness of the symptoms. anemia as a mortality risk is one thing that I would like to talk about. अगर patients के already existing comorbidities हैं, that's when we consider anemia as a mortality risk, because that is a symptom that worsens the prognosis of a person who already has bad comorbidities. So what are the causes of anemia? So the causes and etiology of anemia can be easily divided into two approaches of how you look at it. So one would be the mechanistic approach, and the other one is morphologic approach. So mechanistic approach, let's just look at it in a way that you have blood in your body, right? And then you have anemia. So either RBC production nahi ho rahi, so decreased production is leading to anemia, or increased destruction. के red blood cells बन तो रहे हैं, but they're getting destructed way faster than the marrow can keep up with the production of new RBC, right? Or if we're having acute or chronic blood loss, and that is basically the kinetic approach of anemia. And then if we're looking at morphologic approach, which is based on your CBC levels, right? So your MCV is key in terms of morphology. So if it's microcytic, your MCV is going to be less than 80. Normocytic, it's between 80 and 100. Macrocytic anemia is over 100. So those are the things help you actually to find out what really is causing the patient to have anemic symptoms. And kind of these two presentations go hand in hand in determining actually what your approach should be, what your diagnostic evaluation needs to be, because we have to be very sensible about what tests we're offering, right? So let's talk about the mechanistic approach to causes of anemia. Decreased red blood cell production. So what could be the causes of decreased red blood cell? One, we can talk about के जो building blocks हैं, जो red blood cell बनाएंगे, वही नहीं है. For example, nutritional deficiencies. Iron, that makes hemoglobin, that's not there. B12, folate, those things, right? Or if we're having lack of red cell precursors, if patient के पास comorbidities हैं, he's going through other chronic illnesses, and that's caused the erythropoietin production to be lower. So bone marrow को signal ही नहीं मिल रहा in order to produce red blood cells, right? And if we're talking about increased red blood cell destruction, those are two pathways, right? Intrinsic and extrinsic. If we're going to look at what is causing red blood cell to be destroyed, कौन सी चीज जल्दी से उसको destroy कर रही है, उसको तोड़ रही है? Intrinsic pathways में hereditary pathways are more common because membrane defects, or membrane defects में क्या आता है? Hereditary spherocytosis, sickle cell anemia, and enzyme deficiencies would include G6PD, pyruvate kinase deficiencies, hemoglobinopathies. What are those? Thalassemia, beta thalassemia. So those are the things that are so rampant in our society that we have to always consider those in the increased destruction of red blood cells. So extrinsic pathways में आपके पास आ जाता है autoimmune hemolytic anemias, that includes all the inflammatory existing conditions, MAHA, which is microangiopathic hemolytic anemia, and that we all know TTP is a very prominent condition in which we usually tend to see that. Drugs, toxins, infections, clostridial sepsis can also lead to extrinsic hemolysis, hypersplenism that could be coming in from MDS picture, lymphoma picture, or any marrow malignancies, basically. Blood loss is fairly simple. So acute bleeding and trauma, we have gunshot victims who come in, we have GI bleeding, all those things, acute bleeds. And then there's chronic bleeding with chronic processes, we talked about that as well. But जो सबसे important चीज है जो इन तीनों को अलग करती है, वो है your retic count, right? So retic count we talked about, which is reticulocyte count. We talked about reticulocytes is that those are the first cells that come out of the marrow. right? The immature RBCs. That means like they're baby RBCs. So agar aapke paas baby RBCs are low, your retic count is low, that means कि production ही नहीं हो रही है. तो हर चीज which was happening before the mature erythrocytes are being formed, which is the bone marrow phase and all of the kidney phase where the erythropoietin, all of that is being secreted, वो काम नहीं कर रहा. ठीक है. अगर उसके बाद lower RBC, that means production तो हो रही है, लेकिन there is something that is destroying your red blood cells. Okay, or we're just directly losing it through blood loss. In this one, we talk about a little more on decreased RBC. मैंने थोड़ा सा I went over it a little regarding iron deficiency, B12 deficiency, folate deficiency that would be causing like lack of building blocks. हमारे पास nutritional deficiencies आ रही हैं, red blood cell produce नहीं हो रहा. Inability to use iron, which is the chronic disease. In that one, the red blood cells just not releasing, is just not, they're just not making it because there is low erythropoietin deficiency, inflammatory markers are high, so production is decreased, there is myelosuppression coming from that. And then lack of red cell precursors, those are noted in aplastic anemia, toxins, and sometimes this decreased production could be coming from drugs. So just सबसे important drug we come across is hydroxyurea. That can lead to decreased RBC production, which actually is used in certain conditions. For example, polycythemia vera, and we even use them in sickle cell. Actually, leukemia, sometimes we also use them. Increased RBC destruction, which is a hemolytic process. So we went over intrinsic and extrinsic pathways, kind of similar stuff, membrane issues, enzyme deficiency, thalassemia. Then we talked about autoimmune processes, microangiopathies, drugs, toxin infections, and hypersplenism. So splenomegaly can really lead to extrinsic hemolytic anemia. So we talked about the kinetic approach or the mechanistic approach, as we say, and the other one is morphologic approach to anemia. So in the morphologic approach, the key index that we look at on the CBC is your MCV. As you can see in this low MCV section, the microcytic anemia, you can see that there is hypochromia. So the lack of pallor in the RBCs is prominent over here. Then the normal MCV, normocytic, and macrocytic. So usually macrocytosis is multifactorial, and we can come across a lot of nutritional deficiencies like B12, folate, but also alcohol, liver disease can lead to these symptoms as well. But if आपका MCV is over 115, let's say, so that is something that definitely this is coming from B12 or folate deficiency. This is a figure talking about red blood cell morphology. As you can see, normal, microcytic, macrocytic, oval macrocyte, hypochromic macrocyte, and hypochromia, looking at it. Then shape variation. Shape variation is actually very important because आपका जो peripheral blood smear होता है, you want to look at the RBC shapes on that, right? Target cells, acanthocytes, kind of suggest towards liver disease. Spherocytes, if we see spherocytes, we know that hereditary spherocytosis is something we need to worry about and kind of do some more lab work in order to confirm our diagnosis. Schistocytes seen in MAHA, and then teardrop cells like in MDS, we see sickle cell, Burr cell. So those are the things always important to keep an eye on. You can see the agglutination is noted in a lot of conditions, rouleau formation and multiple myeloma, and one of the multiple myeloma diagnostic CRAB criteria, जिसको कहते हैं, उसमें anemia is also there. So those are very key findings that you can look, you must look at the peripheral smear yourself to figure out what could be causing that. So here is a nice flow chart which kind of guides towards how to go towards your diagnosis. So आपके पास hemoglobin is less than 12. You took a very nice complete history and physical exam. Then you want to evaluate this smear. We just talked about what? The shape, sizes, hypochromic, microcytic, normocytic, all those things, RBC indices. We want to talk about that, right? And then the key in that is that once you're looking at your CBC, how are the other numbers? What is your white cell count? What is your platelet count? What is your neutrophil count? Or if in the differential you're seeing abnormal lymphocytosis, you're seeing abnormal neutrophilia, eosinophilia. So वो चीजें बहुत important होती हैं in order to find out whether you only have a isolated anemia or we're looking at a all cell lines abnormal and kind of a marrow malignant process or infiltrative process, and that is when we need to go towards the invasive procedures and kind of do bone marrow evaluation. So once we know this is isolated anemia, we go towards whether it's microcytic, normocytic, macrocytic. Once we have normocytic, that's when we look at the reticulocyte response. We talked about it earlier. If it's low, that means production is low. If it's high, that means it's either blood loss or hemolysis, right? And once we know that, again, this covers a little bit of older things that we talked about in the previous slide, but it also talks about and differentiates between microcytic, normocytic, and macrocytic anemia. So microcytic, fairly easy. Ferritin and iron status test we need to do and figure out what is causing this. Is it iron deficiency? We have iron panel, usme iron K parameters are low. If it's normal, microcytic, but iron is normal, then we need to consider thalassemia or hemoglobinopathies, right? Like spherocytosis, we talked about it. And then if we have concerns about normal iron panel on the microcytic anemia, then we need to do hemoglobin electrophoresis to kind of figure out what is going on. If it's high, then we know that this is anemia of chronic disease because RBCs are so intact with hemoglobin that they're just not dislodging it. They're just not functioning well. Sideroblastic anemia is the name of it. And that's when we would go towards bone marrow biopsy, kind of look if there's any other process going on. We can also check for erythropoietin levels at that time to figure out whether we have kidney issues or other conditions, right? And you would see ringed sideroblasts over there as well. In the normocytic section, retic count, low, normal, high. If it's low, that means aplastic anemia or pure red cell aplasia. That could be coming from your viral infections, and then you will see inflammatory markers elevated. If it's normal, then we have our answer that if it's acute blood loss, right? And high, hemolysis, intrinsic, extrinsic, chronic blood loss, and that's when you would do the hemolytic workup. The key hemolytic workup includes LDH levels. That's your inflammatory markers. Indirect bilirubin to be precise, and that would be elevated. Low haptoglobin, because that's the binding protein that becomes low if you have a hemolytic process going on. And DAT testing. DAT testing actually tells us whether it's autoimmune process, if it's warm autoimmune hemoglobinuria, or cold agglutinin disease. And further, we also have PNH and other diseases to kind of consider at that time. Macrocytosis, let's talk about that. So we know that on the blood smear, morphology shows MCV over 100. If it has hypersegmented neutrophils, then we know that this is either B12 or folate deficiency. So we'll do B12 folate levels. If they're equivocal, then in order to confirm which one's which, we order the MMA testing, which is methylmalonic acid. और अगर आपके पास hypersegmentation of neutrophils नहीं हो रही, that's when we look at whether it's a polychromasia or target cells noted, if it's reticulocytosis, and that's when we kind of go in and look into the hemolytic process and what's going on as far as your macrocytic anemia is concerned. And in the target cells, if we are having that, then we know that this is liver disease. So you check for hepatic panel, liver enzymes, and all of that. So the key lab evaluation that you want to do in patients with anemia, baseline, complete blood count, right? Which includes hemoglobin, hematocrit, MCV, MCHC, RDW, white cell count, and differential. Differential is key, and always look at the platelet count as well. Reticulocyte count, peripheral blood smear, keeps us sane. We have to do that. Iron panel, which includes your plasma iron levels, your TIBC, total iron binding capacity, iron saturation, and ferritin levels. B12 folate levels, and for the hemolysis workup, LDH, haptoglobin, indirect bilirubin, and then further invasive testing with bone marrow examination. So in the lab evaluation, even though this is basic baseline lab testing that we generally do, but you don't always have to order everything at the get-go, right? So your history and physical really tells you what could be causing this. And that's when you continue to send more and more workup. There's an interesting thing with on the CBC, with which you usually see in iron deficiency anemia, that it causes reactive thrombocytosis. So maybe you have iron deficiency anemia, but you will see your platelet count to be high. So that kind of goes with your iron panel having all that significance and kind of for you to look at it. So now we're going to talk about some case questions. This is kind of the summary of what we have discussed right now. We went over all the big things about your approach to anemia. I hope we are able to understand, we got the idea as to what's going on. So question number 1. 56-year-old male with a history of hyperlipidemia and polymyalgia rheumatica presents to his primary care physician for a routine visit. His labs reveal the following: hemoglobin level of 9.2 gram per deciliter, MCV is 89, which is normal. Creatinine 0.8 milligram per deciliter, iron 35, and the range normal is 60 to 170, which is slightly lower. TIBC 200, borderline low, normal range is 240 to 450, ferritin 385. A blood smear does not reveal any spherocytes or schistocytes. The patient is taking no medication except for Lipitor, prednisone, 10 milligram PO daily. What is the most likely etiology for this anemia? So your options are beta thalassemia, sideroblastic anemia, iron deficiency, anemia of chronic disease, and B12 deficiency. So our answer for this one is anemia of chronic disease. Let's have a look at it as to why. We know that our levels is a normocytic anemia with no other issues that we see. Iron is low, but ferritin is 385. Usually when your ferritin is over 100, we say that this is not because of iron deficiency, right? So we can kind of rule that out on this one. Your MCV is fine, so B12 deficiency or folate does not come in the picture. So the key presentation on this one is the presence of polymyalgia rheumatica, which is a chronic disease and an inflammatory process, which tends to lead to anemia of chronic disease. Question number 2, a 62-year-old female is found to have progressively worsening anemia. 5 years ago, her hemoglobin was 12.2 gram per deciliter. Recently, it's down to 9.8 gram per deciliter. Her MCV is 108, and review of her peripheral blood smear reveals 1 hypersegmented neutrophil with 6 lobes. And her white blood cell count and differential and platelet count are both within normal limits. She carries a history of steatohepatitis due to obesity, celiac sprue, and chronic renal insufficiency. Which of the following is the most likely diagnosis? A, hypothyroidism, liver disease, hepatorenal syndrome, D, B12 deficiency, E, hemoglobin C disease, which is a type of sickle cell. So our answer is B12 deficiency. Let's have a look at it. Why? So we have a anemia From 12 down to 9.8, MCV is 108. So we know this is macrocytic, right? Now we talked about hypersegmentation of neutrophils, and we said that if there is hypersegmentation, then we know that this is nutritional deficiency. And then at the same time, there are three findings that kind of tells us that's hinting towards your diagnosis, right? So patients obese but has celiac sprue. So celiac disease causes malabsorption of your nutrients that you need to keep an eye out on. So B12 is one of the nutrients that are malabsorbed in the celiac disease and celiac sprue. And with this nutritional deficiency, which is already hinted by hypersegmentation, our answer is B12 deficiency. A 22-year-old female presents to her PCP for marked fatigue she's been having for the past 4 months. She has heavy menstrual cycles, but otherwise is in good health. She has been studying for her college exam, so she recently has had a suboptimal diet. Her current hemoglobin is 12.2 gram per deciliter and her MCV is 676. A component of early iron deficiency suspected. Which of the following would you not see on lab analysis in iron deficiency? So we know that this is iron deficiency anemia, right? So the question is, what would you not see on the lab analysis? So A, decreased serum ferritin, decreased transferrin saturation, elevated transferrin, decreased soluble transferrin receptor, increased red cell distribution width. So our answer is decreased soluble transferrin receptor, and it's fairly easy. So serum ferritin would always be increased. Decreased transferrin saturation would be noted. Transferrin, so decreased soluble transferrin receptor is something that differentiates whenever you have a gray picture between iron deficiency anemia and anemia of chronic disease. So always keep an eye out on that. This is not usually tested on the initial panel, but whenever you have a gray area, that's when this test can be sent in and that would give you your answer. A 45-year-old male presents to emergency department with confusion and fatigue. On examination, he's found to be jaundiced. Patient reports a recent UTI for which he was started on some medication. His lab findings include hemoglobin 8.5, MCV of 88, LDH 500, elevated retic count. What is the probable diagnosis? So first option, hypothyroidism, liver disease, G6PD deficiency, B12 deficiency, hemoglobin C disease. So our answer is G6PD deficiency, and here's why. So we know that we have a person coming in with anemia, confusion, and fatigue, and he's jaundiced. So concern for so obviously we have indirect bili, direct bili both elevated, right? He recently had a UTI, probably he got some antibiotics for it. And when you see the labs, you notice that even though it's normocytic anemia, but the LDH is relatively high. The upper limit is 200, so it's over that. So that hints towards hemolytic process going on and elevated retic count. So that tells you that production is good, but destruction is high, right? So that tells us about the intrinsic hemolytic anemic process that's going on over here. I would like to, and I would end my talk over here and would like to thank JSMU ANA for giving me this opportunity to discuss anemia and be able to explain some points to you guys.